The rationale behind remote ischemic conditioning actually origins from ischemic preconditioning, which is a local phenomenon that gives rise to protection of the heart when you expose the heart to short-lasting episodes of ischemia and reperfusion, and then expose it to a longer-lasting ischemic event, then you can protect the heart. It's later been discovered that you not only can do that locally in the heart, you can also do it by introducing repeated ischemia and reperfusion in an organ distant to the heart. For instance, the upper arm, where you can apply a blood pressure cuff, expose it to ischemia of the arm, release the cuff, then have reperfusion, and this is known to release some compounds that actually are protective to the heart. Well, we have done studies back in 2010 where we also studied patients with ST elevation myocardial infarction, and we evaluated the concept of remote ischemic conditioning by measuring the infarct size using SPECT. And at that study, which included 333 patients, we could see that the infarct size actually reduced following remote ischemic conditioning when it was applied in the ambulance during transportation to primary PCI. Our study showed that the concept worked. Other studies were added later on using other endpoints, for instance, ischemic biomarker release, ST segment resolution, and also myocardial salvage by CMR. And then we wanted to figure out, does that improvement that we see in infarct size reduction actually translate into a benefit for the patient? And this is why we did the CONDI-2 ERIC-PPCI study, which is a clinical outcome study. We included patients with ST segment elevation myocardial infarction that qualified for primary PCI. And then we randomized the patient in a randomized controlled trial and in a design 1-to-1 remote ischemic conditioning and standard treatment. And then we did the study using clinical outcome, which was cardiac death or hospitalization for heart failure, and this was a composite outcome measure. Unfortunately, our findings was that the initial results of infarct size reduction actually did not translate into a clinical benefit for the patient. So we have to say that the study was neutral and we found no benefit of remote ischemic conditioning on clinical outcome. I have to say that the most important thing for patients with ST segment elevation infarction would be to secure rapid admission to the hospital, and then we thought that this would add beyond that by improving or reducing the ischemia reperfusion injury. But unfortunately, we did not see that. So with the concept that we introduced here, we actually cannot say that it will change clinical practice. However, there might be other possibilities because you can extend the period, and there has been experimental data showing that if you can expand the treatment period by remote ischemic conditioning, that might influence the remodeling of the left ventricle that is seen after acute myocardial infarction. But that is another trial that has to be conducted. What we have learned from this trial is that we can see that patients with ST segment elevation infarction are very well treated nowadays, and the magnitude of the injury that occurs in those patients with contemporary reperfusion therapy seems to be rather small. So I would say that I cannot exclude that the concept of remote ischemic conditioning works against reperfusion injury. However, the magnitude of the reperfusion injury seems to be so small that it actually challenges the potential for improving outcome for the patient.